Okay, team, let's get started. Today, I want to give a quick update on something that's really starting to change our post-treatment oncology workflow. We're talking about circulating tumor DNA, or ctDNA, and how we're using it to hunt for minimal residual disease. So let's dive right in by talking about a challenge that, we all see every single day, that feeling of uncertainty after what looks like a totally successful surgery. This is the question that keeps us up at night, right? The surgeon gets the tumor out, the margins are clean, everything looks great. But that one question always remains. Is there something left behind? Some microscopic disease that we just can't see? And that invisible threat, well, that's what we call minimal residual disease, or MRD. It's these tiny traces of cancer that can hang around and, as we know all too well, lead to a recurrence down the road. It's really the main driver of relapse for so many of our patients. And here's the crux of the problem. Our standard tools, mainly our imaging, they have a detection limit. They're fantastic for finding tumors you can see, but they leave us with this massive blind spot when it comes to the tiny microscopic burden of MRD. But what if we could shine a light into that blind spot? Well, that is exactly where liquid biopsy and ctDNA analysis come into the picture. It's a tool that's finally letting us see what used to be completely invisible. The concept itself is actually pretty straightforward. As tumors do their thing, they shed these tiny bits of their DNA into the patient's bloodstream. So a liquid biopsy is really just a simple blood test that lets us find and analyze these ctDNA fragments. It gives us a real-time molecular snapshot of the cancer. And what's so cool here is you can see the whole story laid out. The level of ctDNA in the blood is a direct reflection of the tumor burden. When the tumor is growing, ctDNA levels go up. After a successful treatment, they plummet. And, most importantly, if the cancer starts to come back, we see those ctDNA levels start to creep up again, often way, way before anything would ever show up on a scan. Okay, so let's make this real. Let's walk through how this actually changes things for a patient. We'll use a hypothetical stage 2 colorectal cancer patient who's just had their surgery. This table just nails it, doesn't it? It shows exactly the gap that ctDNA fills. Imaging is absolutely essential for telling us where a tumor is and how big it is, but it's blind to the microscopic stuff. ctDNA, though, its whole job is that early prediction of recurrence. So for our stage 2 patient, this moment right after surgery becomes a huge decision point. We're not just looking at the pathology report anymore. Now we can run a ctDNA MRD test to get a much sharper picture of their actual individual risk. And this right here, this is the new pathway. This is the fork in the road. If the patient's test comes back ctDNA negative, that tells us their risk of recurrence is incredibly low. We can feel much more confident about de-escalating treatment, maybe even sparing them from adjuvant chemo altogether. But if it comes back positive, that's a massive red flag. It's a clear signal that MRD is there, and it makes the case for adjuvant therapy very, very strong. And look, this isn't just some interesting theory. This whole workflow is backed by really solid clinical evidence. That landmark study from 2016 by Ty and his colleagues was a real turning point. It showed that this ctDNA-guided approach actually works to stratify patients and helps us make better treatment decisions. So, as this technology starts moving from the research lab into our clinics, what are the big things we need to be thinking about as a team to actually implement this? We have to be realistic here. It's an amazing tool, but it's not a silver bullet. There are still challenges, for sure. We're always pushing for better sensitivity to find those tumors that shed very little DNA. There's the potential for false positives. Of course, cost is always a factor, and we're all working hard to get standardized clinical guidelines really locked in. So the roadmap to making this a true standard of care is pretty clear. We need to keep supporting the big clinical trials to get even more data. We need to develop super clear institutional pathways for what we do with these results. And it means investing in our labs, in training, and this is critical, making sure that every patient who can benefit from this test has access to it. But the potential payoff is just enormous. Widespread use of ctDNA really represents a fundamental shift in how we think. It lets us move from being reactive, waiting for a relapse to show up on a scan, to being proactive, catching that recurrence at the molecular level and giving us a chance to intervene so much earlier. So I'll just leave you with this one question to think about for our own practice. As this kind of molecular insight becomes a normal part of our care, how is it going to redefine everything? Not just our treatment plans, but the entire experience of cancer survivorship and the way we care for our patients for years and years to come.